Good evening, everyone. Thanks for this opportunity. So, as an opening question, I'll start with some basic and simple case. So, it is a USG, it's an extension of clinical examination. In case capsule 67-year-old female, known case of end-stage renal disease, diabetes, hypertension, diabetes, ischemic heart disease, on maintenance hemodialysis. She was going undergoing hemodialysis which was 2 years old. She was planned for CABG. A night before CABG, Permacat got blocked. So ICU consultant inserted right joint AED catheter under USG guidance. Neck was fired, so there was no access. So they did the usual protocol, X-ray and all were okay. So they started heparin-free dialysis. Heparin-free dialysis went for 4 hours, uneventful. So dialysis finished by 1 a.m. in the night. At 1:30 a.m. she started having discomfort and pain at AED catheter site, right joint side. So this was so at 3 a.m. it was the hematoma become large, extensive, and it was extremely painful. She was not allowing any kind of compression. So this was the clinical picture. So they did USG by radiologists. USG showed that there is a pseudoaneurysm from superficial branch of common femoral artery, large hematoma around 300 to 100 cc, hypodense collection with mixed echoes. All arterial system, venous system were no abnormality or any specific finding were there. HD catheter was in situ. It was inserted in superficial femoral vein. So they referred to vascular surgery, but time is gone, so when to connect. So they referred reference given to IR. So ICU team and IR planned for emergency embolization. Seeing that sonography Doppler report, all preparations were done and it was okay decision. Seeing that she was posted for CABG, high risk patient, embolization under local anesthesia. So relatives were agreeable. So everything was planned, but again nephrologist insisted for vascular opening before procedure. So again I received calls, so saw patient at 6 a.m. in the morning. So when I saw patient, so clinically BP was around 100/70, heart rate, tachycardia, pedal pulses were palpable, SD cap quite below in groin crease, which you can see here. So quite below groin crease, and it is like lateral position. Hematoma was medially. So and next history was like HD went uneventful for 4 hours. It was recurrent free, and pain started after the completion of HD. And there was no machine alarm or occlusion given at the time of dialysis. So it was okay. So I did sonography myself, and so I saw this. There is a large collection, hypodense collection, and there is some. So if we see, there is a density difference. So upper one is very hypoechoic, and below that is some kind of between hyper to hypodense. So next finding was collection was far from vessels. It's above the superficial fascia. So there is a artery below, and in this picture it's not clearly differentiable. But if we start from the mid-thara somewhere, so here somewhere was superficial fascia, and this is a collection. So and third finding was I could not capture it clearly. So here was a temporary catheter, and this is a collection. So somehow I convinced them to go for the exploration, though it has to be done under general anesthesia. So I told them there is already blades on the skin, so skin is not looking good, so we should go for the exploration. And under the general anesthesia, groin exploration done, So on immediately after incision, so there is a lot of clear fluid came and it is followed by blood. So what we observed there, so there was a broken catheter inside. So this is just superficial layer. This is catheter here inserted entry point and catheter is broken here.
Here cross. You never know.
No, sir. So I don't think this is because of position or anything. I think they must have hit the catheter by taking suture. That's what I felt.
But it will be quite deep, right?
Huh?
Fracture is deep now.
So here, entry is here.
No, your suture would be proximal. I mean, here the skin is.
Maybe some while taking deep sutures, they must have hit with catheter needle.
Sutures will be at the hub, no? Rather than maybe.
I am just assuming. I don't know what has happened, but catheter was broken.
But did you find the suture there?
No.
So dialysis कैसे हो गया?
So that's why, because at that time it was in continuation. So one loop is going and one is coming. So it was flowing because there is a way. When it got occluded, then it started extravasating. So immediately after stopping dialysis, she got pain and this everything else started. So
how do you explain that it's broken? No, on your ultrasound, you said that you could see pulsatile fluid and all that stuff.
so it's artery, sir.
That's what I'm saying. How you are seeing that within the human?
No, it is very
Because the
superficial.
answer is that it's a puncture. The break is in the catheter.
Yes.
So outside, and that is outside. Yeah. So basically,
So this is a pulsatile flow from artery.
yeah, but where is the artery coming from?
No, it is
So I have seen that artery is separate from
Oh, I see.
So that's what I am telling.
I thought you were saying that there is a pulsatile flow within the artery.
So collection is far from vessels.
Was the angulation very acute?
So she was obese, so I can't.
Where is it difficult to take a deep switch?
So when
What was the expiry date?
I don't know.
Which company catheter?
But I don't think within 4 hours it can break because of angulation or I think they just use arrow
What
indicator.
is the incision you have taken for this?
So yes, so that's the big dilemma before starting the surgery. So I have to put, first of all I thought artery will be somewhere here, but then I scanned, so artery was here. So I have to take incision like this.
Probably.
Yeah.
No, so
No,
generally,
not oblique.
when you are dealing with a huge hematoma in an obese patient, would you like to take a proximal control before getting into the.
So that's what. So that was the plan, sir. But when I opened subcutaneous, it started coming out because it was
Subcutaneous.
yes. So I didn't have to go below the deep fascia.
So what about rest of the catheter? Was
Yes.
it inside the vein line?
No.
How did you manage to get
So I removed. So I removed the catheter. So I removed the catheter and before removing, I took a pulsary suture on the vein. And catheter is pulled out.
You have a picture of catheter?
Sorry?
You have a picture of catheter?
No, sir.
No. So the other end of the catheter. So now this is in two pieces.
So no, it's not in two places. It's still connected. It's still connected.
It's still connected.
It's still connected. So that's why mosquito is applied. Then we traced for the vein and took a pulsing suture and then removed the catheter.
Okay. So correct description is not it's a it's not really pseudoaneurysm, it's a.
That's what. Yes. So the radiology report was that, and as per the report, they have planned embolization for this.
So moral of the story is you
It's
got
coming, sir.
very good relationship with the nephrologist who insisted on
Yes,
the
sir.
therapy.
So
That it's very important
yes.
because otherwise they would have done a procedure where they would have not found
sir, your chief.
वो तो इसीलिए तो बोला था नेफ्रोलॉजिस्ट.
So he called me 5:30. I have to here for he.
Insisted on asking.
I have to hear you for 15 minutes while you didn't receive call and all. So what?
Considering he is posted for CABG, is good he didn't call the cardiac surgeon.
So cardiac surgeon denied, sir. So they called cardiac surgeon because it's your patient first will come and do. So he denied because I have 3 cases in the morning. So
How many cases you have?
so
So
catheter.
why did you not put another catheter?
So yes, from same vein, because that skin was not good looking and it was having already blebs and it is very thin. So I was expecting some kind of wound complications over there.
So take home message is always under imaging.
Sorry, sir.
Take home message for this presentation is, what is the take home message?
So yes, so first of all,
So
I
first of all, when the podcast was blocked, they could have put wire inside, removed it, put a new one.
so it has happened in the day before CABG evening. So I don't think they might have found someone to do all these things. And
Day before.
evening means after next day she was having CABG. So if anything we have to do like thrombolysis or any kind of intervention, cardiac surgeon would not have given permission for any kind of things. So they just wanted to sort it out for now and put in catheter and just finish the dialysis and take her for CABG.
The CABG done.
Was it done?
No, so it's coming. Yeah. So remove the EG catheter, venous vein was closed. Again scan made. I got EJV. So EJV EG catheter was inserted. So she had some wound complication. So obviously next day CABG was deferred, and again the wound was managed with dressings and bag. So EJV line was converted to pump care. And after 4 weeks, she underwent PTCA, complex PTCA, while left under USG access in presence of vascular surgeon. So take home message: in case of discrepancy in clinical and radiological findings, scan yourself. And USG can be extension of a clinical examination if done meticulously and combined with proper history.
We need one question in this, that in this kind of situation, you found that there was a hematoma medially. You found that the main vessels were well away from the hematoma. So when you decided to explore, what were you anticipating?
So I never thought about this.
This is totally
Yeah.
unexpected.
So first of all, I called for the help. So I called Dr. Ritesh. You also come. So we might have to just compare and see what's happening. We might not be having control. And Katla was busy. So we have to take, because she was in excruciating pain.
No, but what control would you have?
He was expecting arterial.
No, but he is not
expecting arterial.
No, I was not expecting artery. I was expecting something else.
Like what?
Means other than means
Actually, main arteries, you know, are the vein. Vein is probably, because it's from the vein, you know that it has to be something to do so that whatever injury would be along the track.
So my plan was clear to go for the artery first and take a control at inguinal ligament, because artery I was seeing was okay, but before reaching there, when I opened subcutaneous, it started coming out. So there was.
So just a thing, you know, when we've had some of these cases, what we do exactly what you are saying, but we don't take an incision where the swelling is. We go above it whenever it is possible. That way you have your proximal control and you are not going through the actual collection. So that is one thing we have done consistently. And like you said, no, you are lucky that they allowed you to do it under GA. Because most of the times we have to do it with somebody pressing on the groin.
Yes.
That is painful.
What made them find out that it was tunnel?
So there was a continuous jet coming from somewhere in the superficial area and going into the collection. That's why I think so. They must have thought.
Was it a consultant or resident?
I think night it must be resident.
If you would have called first one,
But this,
you know, they called you first, what would you have done?
Sorry.
You said you saw the patient next day morning.
Yeah.
If you would have attended at same night.
So might be depending on again clinical examination history and serology. Safety.
No, my point is you would have changed to other pump cap.
Sorry.
Changed to another pump cap. Whole thing started because pump cap got blocked, right?
Okay, before you
it
went
was
on.
not bomb cap, it was an HP catheter.
No. Initially it was bomb cap.
Oh, that was, oh.
Dr. Patel presenting. Yeah, what?
Thank you, Dr. Vivek. Next we have Dr. Pankaj Patel, who will be presenting a case moderated by Dr. Alibaug.
पहले ये पूरे में बस इधर बस इधर
You have to moderate.
मॉडरेट
सर वो कोविड वाला है क्या सर?
कुछ सेटिंग करके आए क्या तू?
इसके साथ
इसके साथ?
अभी इसके साथ हो गया अभी उसके साथ सर उसके साथ उसका ही सेटिंग होता है
Yes sir. But he was not able to
Good evening. For people who don't know who I am, my name is Dr. Pankaj Patel.
But that guy knows you.
So I decided to jump the queue primarily because it was in continuity with some catheter-related problems. So similarly, a case like this is a complication of ECMO. So 62-year-old male, he was admitted in the ICU with fever and multi-organ failure. So they decided to put in an ECMO. Now they had a right femoral arterial line and a right IJV line. This right IJV line for ECMO, what they had done was through the central line, they put in a guide wire and over that they exchanged and put in an ECMO line there, whereas the arterial line was as usual blindly put by the intensivist who's there. So on starting ECMO,
Not at all.
no, on starting ECMO, hypotension and cardiac arrest. Patient was resuscitated and then suddenly they noticed there is a huge swelling in the neck and on the anterior chest wall. So by then the ECMO had to be stopped because patient already shocked and they got an ultrasound done. Now ultrasound showed that there is a large hematoma in the neck along with the anterior chest wall, and while doing the ultrasound they noticed that even the right lung has collapsed and there is pneumothorax there. So I was called in to see this patient. When I looked at the patient, by then they had resuscitated, given blood, and patient was hemodynamically stable, otherwise got on ionotropes. So looking at the whole picture, what do you think I should have? What would you do? Sorry, not me. What do you think we should do now? There is a large neck hematoma. Patient is ventilated, ionotropes,
प्लेटलेट्स
all normal.
कोagulation parameter
Yes, everything normal. There is no problem about that. But large hematoma in the neck, pneumothorax.
Can they be shifted for CT?
No, he was not in a condition for any of those things. So, what is it that we should do in such situation?
right activity vector
So, do you think that we should explore?
neck vessels and chest.
Patient was too critical for any of those things to do. Just cardiac arrest, research related, various things.
So when you saw it, because kids like more was going on.
No, it had been stopped because there's a large delay, na? So it stopped.
Was there a pericardial echo?
No, there was no pericardial effusion.
Basically, it is related to the wiring that they have.
Do you think that one should go ahead and explore this patient?
Contrast.
Any question? Huh? Because the whole thing was there, they had stopped everything. So we just saw that the So the thing was, it was so difficult to do anything. The patient was so hemodynamically unstable, and the intensities and other people kept on saying, "Hey, yaar, isko kholo." And I was very skeptical. I said, "No, I think I will sit over it." I said, if patient remains like this, if there is a hematoma, we are not doing anything, there is no ECMO going on, and patient is managing, then I think we should hold on. Unfortunately, they were insisting, we have to do something, we are going to lose this patient.
Explore what?
Pardon?
Neck or chest.
So, explore the neck.
Pneumothorax also, no?
Yeah, exactly. So it was not going to be very easy how to go about. So what I did, I'll tell you, I didn't get a.
Put a ICD and see.
So what I did, I decided to take this patient in the cath lab. I shifted the patient in the cath lab, and what I did was I punctured the right antecubital vein, right hand. Because this was not there, I didn't puncture the lower end because there was another femoral catheter there. So I said, let me try and see where we are in this respect. So, anyway, answer is given. So I did this, and when I did this,
So you punctured the vein.
yes, antecubital. If you can see, this is the ECMO catheter. I thought that this is the IJV. Now what happens is when you are injecting from lower down and the catheter, we are finding it very difficult to push from this side, and it was, not going up any further. And when you inject, obviously the blood flow doesn't go into the IJV any further. And there, the catheter is now here.
It's going upwards.
So,
the catheter outside the center.
yeah, looks like if this is the IJV. Question is whether that's IJV or what is it?
No, your endotracheal is seen next to it, right?
Correct. This is not endotracheal. This is the ECMO catheter.
Oh, is it? Okay.
This is the ECMO catheter.
See, that is the clavicle there you can see.
This is the clavicle. ये क्या है? बीच में जाता है. ये.
So इधर
ये वो ECMO catheter.
बाहर है.
ये तेरा endotracheal है.
It's not intraluminal.
But you mean to say ECMO is not inserted right up to the
Are.
So it's in the carotid problem.
No, but it has
नहीं.
It is not. It is.
Yeah.
It is
So
not.
it must have leaked around that hole only.
Which hole?
The one which punctured.
So IJV का इधर ना. So that's exactly. But when I did this to check
This
here.
is going in the external jugular vein.
So I was not very sure now what to do. Okay.
So you can inject in through that ECMO catheter and see what it is.
So when we opened the ECMO catheter now, we couldn't get anything out of it. Everything had clotted or whatever, we couldn't aspirate anything. Because ECMO was stopped for more than 2 hours now. So we couldn't get anything out of it. So what we did was we went from lower end. Because then we get a good purchase to go into the IJV. So we went there. Now can you see this picture here?
Go through and through.
This is the IJV.
So any other angle, sir? Any other angle?
अभी जो है वो देखना है क्या है ठीक है, एक कभी चलता है कभी नहीं ना.
It must have gone into some finished tissue now.
Now the thing is that they were very sure when they aspirated their blood, support, everything. I said, okay, fine. So now with this picture, I said, have we gone through and through? But now, I was a little concerned because now there is no aspirate from the ECMO also. I said, what has clotted, what has happened? So I was not very happy with this picture. So the next thing we did was we punctured the femoral artery on the other side. And I said, I need to check onto the arterial thing, whether it's gone into the subclavian or the carotid or what. We did ultrasound, we were sure that it is not the carotid. Because ultrasound done there showed the carotid was not there. So, this is where the end of the catheter is. This is the subclavian artery. Now, as you rightly say, different angles. So we thought, okay, is it in the subclavian artery? Or is it gone through and through the IJV?
Through the IJV.
Okay. So then the next thing we did was we put in a wire, we put in a catheter in the subclavian, and we realized that it is not aborting, hitting anything.
Would have got arterial blood, no? Had it been an artery.
Yeah, but then probably it's not it.
Remember, this is not a puncture. This
No.
is somebody had a central line.
Correct.
Which you put a wire.
Correct.
And it did that.
Correct.
So, how do you
But
explain that?
when they started ECMO, they would have got arterial blood there.
That I don't know. They said we got good backflow.
They must have put into the vein and then out of the vein. But they must use the other end. You have to
Fluid.
hold the wire. See, the wire have been out.
on aspiration,
The wire must have gone.
on aspiration, good blood flow, right, sir?
Pardon?
On aspiration, good blood flow when they started before that.
So they say.
Those, so they say. And that's why they started ECMO.
They must have used the other end of the wire.
So, again,
So when you look at the whole thing, I said this is very confusing because it's either gone through and through the IJV. The subclavian was clean. So what we decided, we put in a wire across the IJV, kept a balloon ready. Say just in case.
no, you mean you took a wire through the ECMO catheter.
No,
You punctured the IJV separately.
Femoral vein.
no, we went from femoral vein down, na? Because IJV, see, originally I did it from the anticubital vein. Then because my catheter was not going into the IJV up from that angle, we punctured the common femoral vein and then we went up.
So next to the right.
So that's why the previous image that you see here is the image where the catheter is coming from down. Okay, and here we can see as if it is going through and through. We took different angles and various things, but everything was so very close. So now with this, we kept everything ready. A catheter across wire, and we said, okay, fine. We go on withdrawing.
Sir, one question, sir. While putting this catheter and wire, did you get resistance with that ECMO catheter?
I didn't put it. It was put by an intensive.
From below.
Sir, from below.
No,
Femoral.
no, we didn't find.
Like you check for the subclavian
Correct,
artery.
correct, correct. For the vein also we felt that nothing was touching.
Okay.
What is this?
That's the endothelial
No,
tube.
no, no. That black thing like this.
The middle.
Like a needle.
No idea.
So good answer.
So eventually, what had happened was this particular ECMO catheter had gone completely outside. It was not in the vein. Nothing was there. Okay, and so this is how I just pulled out. And they had done an ECMO injecting 3 liters of blood from here into the chest without checking properly or whatever. So femoral artery से blood निकाला, chest में डाल दिया, the patient cardiac arrest. And the whole thing, we broke our head into finding out what is happening, what is not. So, and then I put in an ICD after almost 25 years, maybe moved with them, because there is nobody to put in an ICD on the, so I inserted an ICD also.
Survived?
Nah. Subsequently, I
When?
after some 5-6 days. इधर तो कुछ था ही नहीं था. There was nothing here. I don't know how they managed. I think probably what has happened is the wire must have slipped out while removing this. Because that ECMO catheter thing is also quite a large bore thing, and probably they just pushed it down. And I don't know from where they got blood. So at the end of the day, catheter related problems are significant. So,
I mean, question to that is, whenever these interventions are done, it has.
so we had a big discussion on this, especially in intensive care unit and all. These people, when the patients come in emergency, in spite of telling all these people, very few intensivists are using ultrasound guided monitors and various.
So it should be
because
very
they are
careful.
not- Exactly.
I think Pankaj, in this sort of situation, you know, I think there are two problems which commonly people face. One is they use the standard, not the full length guide wire which we normally use. We use the one which comes with that.
Comes with that.
the set. So invariably what happens is that chance of it slipping out is more because it's a much shorter. And the second thing is that this is very interesting because this patient already has a catheter, functioning catheter.
Exactly.
So that means that there has been a major wire.
So the only thing, the wire slipping out
And one more thing which one should always remember, that whenever you have to use force for endovascular, there is something wrong somewhere.
similar kind of a case, one more case was there which I have not brought it here, I have it. Same thing, they were putting a port. And the same through the IJV into the bifurcation of carotid and subclavian, the port. And that as soon as he aspirated, he realized that he is into trouble. Now, even those port ka sheath and everything is quite big. So the only way we could have dealt with it is to put in a covered stent graft. But that again was very tricky because there was a junction. But we salvaged. So many a times, even when you are doing under image intensifier, and these guys are not so used to, they tend to push very blindly without checking on where the wire is. And especially venous side, you have to ensure that the wire is gone through the right atrium into the IVC. You have to check that. Then only you should push. Otherwise, you should not push.
Thank you, sir, for a wonderful presentation. We next have Dr. Piyush Jain, who will be presenting a case, the moderator being Dr. Anish Mapre again.
लेकिन उसमें कोई इनपुट ही नहीं दिया, वैसा वैसा मॉडरेट जाता है। हाँ, मॉडरेटर प्लीज।
Good evening, everyone. So continuing with our theme of complications related to catheters. This is a case where a lady lost her fingertip. So the question was, are we paying price of some imprudent investigations as we go along? So this is a case of delayed referral of acute dystonia. 24-year-old lady with no comorbidities, had family history of heart disease in father. She had some chest pain on her, she was not sure of. They did some ECG today, echo they were normal. She went to Apollo and they said, okay, let's just do an angio routine just to rule that out. We never know what's happening these days. On prior investigation, she was found to have some low platelets. So she was diagnosed as ITP. The hematologist gave some INE, IgG, and the platelets returned to normal. She was planned for the angiogram right radial approach. The coronaries were normal. Post-procedure, she had a tight compression bandage as usual. She was not on equestrian at that point of time. They gave her during the procedure as standard. By leaving, the patient started complaining of pain in the hand. So they said, okay, let's just use the compression. Nobody saw her that night. She was just fine. The next day, the patient had acute kind of hand, painful. So they just said, let's do a Doppler. She showed thrombus. We started around February. So then she started developing some tissue loss. Slowly the discoloration and everything started. Cardiologist saw her, requested for a CT. The CT showed the whole radial artery was gone, completely thrombosed. So then they started wondering what had happened. Then the next physician saw and they said, okay, let's continue with medical management for now. Asked for a cardiac surgeon, said, okay, radial artery thrombosis, it's warfarin, so we wanted to start anticoagulation. Started on Clexane and the next day started on warfarin. She kept developing, she kept having pain, she was not happy, but then the patient was discharged, okay, this will settle, take medication. I was not involved in this stage. Until a month later, she came to the OPD because there was a medical legal case filed now, so they started wondering what is happening. In between, she had gone to multiple doctors. So when she came, this was her present condition. And she was on Ecosprin and she was on Vessomag 10 milligram. So I don't know from warfarin how did it change to rivaroxaban. I think it started with during discharge she was supposed to be on warfarin. I saw some PDN test being done which were never up to the mark. Then she met some rheumatologist, another rheumatologist who said, okay, take this anticoagulation, this equestrian. Then I contacted Marcus because I started getting multiple calls from everybody and saying, oh, so she's all right now, she's lost a tip of her finger, but then I started getting multiple calls from people saying, okay, what is the, how do you treat this, what do you do, what else should have been done, so the multiple hospital reviews and the hematologist was saying something, the cardiac surgeon was saying something, the cardiologist was saying something. So basically I just went through the review of literature. So there are some preventive measures, usual ones being use of ultrasound, avoid multiple punctures, smaller sheet, 5 frames is always better, 6 and 7 have similar rates of thrombosis. Vasodilators, if you find any spasm in younger patients, give anticoagulation. 5,000 heparin is always better in adults than 2,500 or low dose heparin or anticoagulation during the procedure. Then the hemostasis methods remain the same, whether you just compress or not. But if it's non-occlusive compression, it works better and the rates of thrombosis is low. And then access through distal part of radial artery through snuff box.
But usually in a situation like this where you are documented thrombocytopenia, would you still give full dose heparin or would you stick to a lower dose?
So although it was diagnosed, but after the IV regime, she had 3.7 lakhs platelet count. I would give full dose heparin. I would even not decline myself from any antiplatelet if I need. And that was the initial count was also 77. It was not less than 50.
Now what happens sometimes it is not count only which is important. It is a functionality. And that sometimes can get, of course, we are talking about not bleeding, we are talking about thrombosis. So it's exactly opposite. But just, I'm just wondering that sometimes we just go on that number, whereas actually, commonly we used to see this, when these cardiac guys, they do low poison temperature, they give aspirin and they give clopidogrel. And if you do the patient will come with the sugar.
So, what was the cardiologist protocol before the sheath is out?
Before the sheath is out,
I mean, routinely do they check PGTK?
do the routine check
It's
So the point is, for any upper limb punctures, you do not have to wait for the PGTK to come down to normal. Number two, you have to take the sheaths out immediately and let the vessel bleed. Then give compression. You are not giving compression to stop bleeding. The vessel has to bleed first, whether it's from bleeding or brachial. So that way you are reducing the chance of thrombosis.
I think some people also give a vasodilator before the
Yeah. But it has to bleed. Unlike in a groin puncture.
Rather than compensating the spasm, that causes the problem.
So we see with routine practice when the cardiac surgeons take radial artery as a graft, you always check whether the arch is patent through the by doing compression and stress. Now, I always tell this cardiologist that or even the intensive, because I see quite a few similar complications in intensive care unit where they put in a radial line. And that radial line also produces similar kind of thrombus and thrombosis. And the number is not small. Okay? And people who don't have an ulnar artery, which is filling up the complete arch, land up with this kind of a problem. So the first thing is preventive. Forget about rest of the thing. So what is more important is which radial artery you should not puncture is a vital decision making clinical which needs to be taught to the cardiologist and the intensivist.
The recent machines, vascular have that and one question was, why did they do angio?
Chest is big. I think the other issues also, in this type of situation is that when you find that it's ischemic, whether there is a role for an intervention.
So the thing was that because she presented to me a month later, there was no left at that point of time. But if they would have called me, that's what I told them, that if you would have asked the hospital CEO called me and he said, could we have done something? I said yes. From post-operative when you start realizing this issue was getting worse. She had rest pain. That is the time to intervene. You could have done the thrombus, you could have taken it out, you could have done multiple things to prevent this. Explode and open or do anything, but you could have done something at that point. It's too late. So then there was basically somebody was trying to push it.
She was figurative. Or the whole figure.
But this took 6 months. This is case of November. She recently came to OPD about a month back, and so about 6 months was gone by the time she had to endure that much of pain and all the others. So the next thing was they were trying to talk about the treatment protocols and what all we have on guidelines point of view. Basically, when they kept trying to push it towards warfarin to say that anticoagulation is what it should be. The papers that they were trying to quote were all older ones, some new ones, but again, the evidence, I don't even think they actually read those papers when they gave it to me.
No, the point is, this is all fine as long as there is no tissue loss. The moment you have a tissue loss, intervention has to be done.
So that one proof up was already done. This was the second one, when they were trying to push her towards warfarin, no antiplatelet. That's when I spoke to Marcus and I was like, oh, we need to put her on antiplatelets. So all the papers that they were trying to quote and everything, if you actually go through them in details, they all talk about antiplatelet plus anticoagulation. that is when things become better. And again, these are for just radial artery occlusion. They are not talking about tissue loss. Tissue loss is definitely intervention when in acute phase. I think I have this picture which was 3 months later, and now she's redeveloped a bit of the nail, but she's lost some part of the finger.
Pain is less.
Pain is okay, manageable. Thank you.
Sympathetic block होगा है? Sympathetic block.
So after a month, she didn't have much pain. Initially, so of course, she should have just opened and
Prostaglandin
It is litigated, right?
yeah.
Prostaglandin infusion.
Sir, on first day, probably I would have just explored. I wouldn't have waited with the tissue loss on this day.
My experience.
So when will you involve?
Cases,
A month later, sir.
and these litigation phone calls come, they invariably is recorded while you are answering. I've got at least 2 people who were recording while I was. They had their mobile phone and they were recording. Or mobile, when they are calling you, very careful when you answer on this because they actually record.
First of all, you should never enter on mobile.
Even when they come to the room,
Even the WhatsApp chats are being used as documentation now.
they stand with their mobile in their front pocket and they are actually recording what you are talking.
Good expression would have had. I don't know, it's immediately also expression I might not have had.
Thank you, Dr.
After 1 month, he was
No, sir, same day also.
immediately you have to open social and see what's happening. If there was a tissue loss.
There is small digital
Next, I'll be presenting. It will be a case, 2 cases of SMA aneurysms. I hope everyone can see. So the first case, my moderator is Dr. Paresh Pai, sir. The first case is of an SMA branch aneurysm. Now this patient was a 76-year-old female admitted with diarrhea. There was nil abdominal pain prior to this, and the USG abdomen shows a large pulsatile mass anterior to the aorta. The CT angio confirmed the diagnosis. The celiac artery was occluded from the ostium, and this patient had a saccular aneurysm of about 1.8 centimeters in maximum diameter coming out from the SMA. This was basically a branch which was not the gastroduodenal artery, as you can see the gastroduodenal artery here, and the ipra going on the other side. But this was a collateral which was on the side of the SMA going and filling up the left gastric. So I did an angiogram. This was basically a RDC, and I injected it to the SMA. There was an aneurysm which was there coming out from the branch. A more selective sort of a shoot showed the aneurysm, a saccular in nature aneurysm. I took a burr, 5 French, and entered through this artery, through the inflow, and I started coiling the sac. Now this was basically a framing coil, which followed with more coils, and basically after about 9 coils, what I got was complete exclusion of the aneurysm in this case. There was no post-op complications. There was no symptoms in the first case at all. The diarrhea resolved in 48 hours. Lucky for her, but I don't think the aneurysm was connected to the diarrhea. And the patient was discharged after the resolution. Now, whether or not this should be intervened or not, so the data shows that there is a high rupture rate at presentation, with almost about 50 to 70% of the aneurysms being from the SMA branch. And whenever we have these mesenteric artery aneurysms, even if the aneurysm is less than 2 centimeters in size, the rupture risk is also more, and especially pseudoaneurysms are higher risk of rupture. It is high mortality when ruptured, and the treatment is usually recommended, especially in all, whether it is symptomatic or asymptomatic aneurysms, regardless of size. This is aneurysm, sir. It's yes, microtic. Now, going ahead, this was a patient of a ruptured aneurysm of the inferior pancreaticoduodenal artery. This was a 40-year-old patient, lean, mean, no comorbidities, and came in frank shock. The patient had no use alcohol history, smoking or prior illness, and a CCT at the casualty showed that there was a large bleed in the second and third part of the duodenum with contrast pooling around the pancreas. The CT showed that there was a lot of blood in the mesentery, but per se could not identify the vessel at all going down. You can see here just below the liver, you can see a huge pool of contrast. This is the acute phase of the CT scan, where you can see a pooling of contrast just in the second, third part of the duodenum, and the patient being in complete shock. So here I went in, I did first an SMA angio thinking I don't know where it is coming from. So the SMA angio looked quite good. The celiac artery also, you could see the splenic going in, but the hepatic having a lot of resistance inflow. A more selective shoot of the hepatic artery showed that I could not even see the gastroduodenal artery here. A selective shoot of a gastroduodenal artery also was not filling well. Now, this was more of a dilemma because we have to salvage the patient, but cannot know where, not knowing from where the bleed is coming from. Then I negotiated into the IPDA, the inferior pancreatic duodenal artery, which is coming from the GDA going down. And the IPDA for the first time showed a small little aneurysm coming out from one of the branches of the IPDA. A selective angio showed that there was a small unruptured aneurysm and a big ruptured aneurysm which was there proximal beyond it. A more contrast shoot, a much longer contrast shoot, showed the active leak of contrast into the mesentery. Now, this was again a flaming coil. The aneurysm size I did not know, so I went to the 2 centimeter coil first, followed by keeping it packing all the way down to the proximal aneurysm here, and thereafter going into the IPDA, the retrograde branch, which would have filled from here down as well, and blocking this because I didn't know how much of connection this loop had. So I had to go proximally and coil it up. So after this, there was no flow which was going into the sac, and the patient stabilized quite well. I discharged the patient about 4 days post-intervention. Basically, the intention was that these cases which are there, per se, even the CT does not show anything. The CT can be completely blind because it might show blood in the mesentery, not knowing from which artery is bleeding. And BSA for such cases are also quite difficult because you don't know where to go. You are basically just going blind, as Pankaj Patel sir's case was more blind. We have to go in and then find out the problem, especially when the patient is in shock. So such things, I went to the literature, found out more than 40 to 50% of ruptured aneurysms of the SMA or the celiac is mostly in the IPDA. So whenever in doubt, the literature states that go and search the IPDA or the gastroduodenal artery and you'll find an aneurysm in it. And in the first case where the celiac artery occlusions are high, the number of SMA aneurysms are more. So even if there is a rupture, the collateral circulation may have aneurysms in place. Thank you for your attention.
So, what was the etiology of these aneurysms?
Degenerative. One was pancreatic. So the first patient, the second patient, the young patient, we searched for pancreatitis, we searched for collagen vascular disorders, but nothing was there in the ruptured aneurysm patient. On the other hand, the first patient which had, she was a lady who was in her late 60s, 70s. So that could have been because of the celiac artery occlusion. That's what, sir. The literature states that there are multiple collateral circulations which may form, and these collaterals may get aneurysms which are degenerative in nature.
So, do you make any attempts to try to see if there's any other feeder to that aneurysm, primarily in this area? Because sometimes what happens is you knock off one side, and it continues to bleed or come from the other side, and then you don't know where it is and what it is.
So, sir, I primarily coil the sac. So, I understand, as you said, there has to be backdoor and front door coiling, which has to be done. The problem is with a high flow aneurysm, the backdoor coiling is actually very difficult because the coil tends to fly away. And there, a plug would have been a better option instead of doing a coil. But invariably, it is the backdoor, sac, front door coiling, and then you come out. Collaterals, yes, but if the sac is completely covered densely, then the chances of decanalization is much lesser.
What about along with the product?
So glue, the problem is control. So the commonly available glues which are there are micro characters with balloons which are proximally kept. So that reduces the flow into the sac. That probably can be used, but they are not launched in India yet. But glue along with the coils may be an option, but in a low flow system, not in a high flow.
What side of gloves?
20% oversize.
Anil, are there reports of treating these patients with flow diverters the way they do it for Europe?
Yes, there are. The problem with the flow diverter here, I had actually kept an option for that as well. The problem with the flow diverter here is that there were multiple branches, as Sir said, coming over into the sac, barring the main entry and exit point.
Already ruptured.
The second one, the scapular ones had multiple branches. So by keeping a flow diverter, I would have still filled the sac in that area. So hence spoiling the sac was more important here.
So if there are no branches or nothing, would the flow diverter work in mesenteric aneurysm?
I have stented SMA double aneurysm just with a barred covered stent instead of even
covered
flow
is
diverter.
different. Flow diverters are of a different.
Agreed, sir, but they go from, they are covered stent. So they are useful, but
They
the
are not
cost
covered
is
stent.
high.
They are not covered. Flow diverters are not covered.
They have a covered and uncovered parts.
Flow diverter doesn't immediately, it takes
Why? Yeah. But they are very small aneurysms.
bleeding aneurysm, so it gives
No, no, bleeding. I'm just saying a saccular aneurysm. Just a thought. Whether in Europe, the bowel ischemia,
Sir?
you consider for bowel ischemia.
Yes. I explained the risk of rupture versus risk of bowel ischemia, and most of them agree for it, sir.
So the second one, CT did not pick up.
CT did pick up, but they did not pick up the inflow vessel. They could not identify the inflow vessel.
I have one question. So, in such conditions, can we use NTG? If vessels are in spasm, so can we use NTG and see the anatomy?
The problem is in the bleeding patient, the patient is already in shock. So if you give MPG, it is always going to be consequential. But the PT will still talk.
And I will with the bleeding aneurysm, it is very difficult to go to the other side of the vessel, to back door and front door. So it is best to coil the sac and come.
Correct.
But what was so much resistance for the GDA and
So basically the branches were all in spasm. So blood was getting diverted into vessels which were already not in spasm. Thank you very much. The next topic would be Dr. Ritesh Gaikwad. And the moderator is Dr. Ganesh Kandekar, sir.
hello, good evening everyone. This what we are going to present is not a complicated case. They are just simple cases. She's 71-year-old female case of diabetes, hypertension, and coronary artery disease with injection fraction of 45, creatinine of 1.2, and ABI of 0.2 with a heel ulcer on the lateral side. Did an angiography which showed multiple blockages proximal SFA and mid and distal SFA were normal, and this was the picture which was very weak, that is internal calcium or whatever is there in the P2 part of the operating artery. Rest there was significant stenosis in tibial lung, and the outflow was 88 and peroneal. So I planned for atherectomy because of internal restriction to calcium.
Which atherectomy device is this?
All right. Yes.
Which one?
Still.
Is it crossover or anti-grade?
Process. Because it was possible. First, we had possible SFA athletic then
Which sheet size is?
so it was a 6. And the third was 2 mm. And this was post-athletic NGO, which shows not fully open proximal SFA. Then we did a repeated athletic. And after the repeated athletic, it was quite open, large. Then we casted with normal balloon, both SFA and populated.
PCB or plain?
So we didn't have that size of PCB, we did plain balloon.
The whole idea with athlerectomy is
Vessel payment is a PE.
Yes, sir. But we didn't have the size that time. And we did plastic also at the same time. And this was infra-populated angiography, completion angiography, which showed very good better ATA and peritoneal. And post-operatively, she underwent deferred back and then scintigraphy. And this period was just 3 months with still palpable dorsal surgery. And this was in spite of ulcer in lateral side of the heel, that is in peroneal or PTA territory. This is other case.
What was the PAT?
What?
PAT. Pedal acceleration time.
So I didn't check it. On ultrasound, now he was 87 years old, retired veteran. No case of diabetes, hypertension, coronary artery disease, with structure of 40. Right to the breast pain and popliteal was palpable in this case. This was his angio, which shows the occlusion of TPT at the origin with disease with diffuse narrow PTA, only flow was posterior tibial artery. Even dorsal space was occluded in the origin. And there was some stenosis at common plantar artery. He was having planned for athlerectomy. Specifically in this case, the athlerectomy was selected because it was at the branching bifurcation point, so that we can preserve the anterior
Size of 1.5.
1.5.
in such situation, do you not want to protect the ATA by putting a wire across?
Sir, this athlerectomy will break this other wire. And whatever wire we are using for this athlerectomy, they are not coated, they are just steel.
So your wire is in peroneal.
Yes, sir, this is good. Posterior.
Have you had embolization risk with that white solution which they give?
Yeah. What?
Embolization risk with the white?
No, it was not there. Actually, this is done for 25 seconds, stop for 25 seconds, then infuse it with the solution, then again continue cycle for 25 seconds. There was absolutely no embolization. So this was after your plastic. The whole DPD was open. Then we put a wire into the ATA before the plastic, so that ATA doesn't go off. Then we plastic the removal artery. this is the completion ratio. And also we give a common camera, I think plastic or 1.5 only. And this one is poster.
Ritesh, could you have used an IVL in the first place instead of an nephrectomy, being the calcific etiology of the disease?
The first is just
We have had instances in which atherectomy has dissected the calcium and caused the perforation.
first perforation. No, but we went through and through the urine. I didn't have
Even
this
in the
kind.
true room. Because the calcium edges are quite rugged, so many a times the atherectomy device itself can cause a perforation by lifting the plaque.
That can happen to burning also. So,
What this whatever device I have used, what does it does? It just hits the hard part, and wherever there is a soft part, it reverses back.
Which is the wire you use?
Wiper.
Wiper is called atherectomy. First
We
wire.
put.
So you are sure that you are interrogating.
So without IVS you
How do
can't.
you choose an atherectomy device? There are 3 available. How do you choose between? And what precautions do you take before you commit to an resource like this?
No, not this, second one.
Second,
Because of the house.
But generally, using atherectomy, how do you decide I use stem, not extreme, or not rotarex? How do you decide? Is there any criteria?
Sir, for thrombus, yes, for thrombus, whatever is within 90 days, we can do bars for rotaries. But for calcific lesions, I don't agree that we use this atherectomy device like that. I felt better with this from first place because of this.
Embolization chances are more or less individual protection device. How satisfied are you with the stent 360? How satisfied, honestly, with this closed loop? How satisfied? What is your personal experience? You feel that it cleans up things nicely, or you feel that at least
Sir, if we debulk the calcium, that's it.
it's a decanalizer.
We just at least decalcify so that our plastic works better with the BCD.
Something like a jet stream with its blades. Don't you feel it will shape better than a Reptilus rotating?
The Jetson cuts very well. The next mode is much more powerful in Jetstream. Orbital, somehow the cutting power is not good. When you cut it 2-3 times also, it doesn't cut too much. It is
It is sandpaper.
It is sandpaper.
Yeah, like a pulverizer. Same thing is the.
That's the reason they don't require aspiration. When the particles are very
It's
small.
very fine.
With jet stream.
They don't recommend a
It's
filter.
all-
They
No,
don't
no,
recommend a
with jet
filter.
stream we may have.
Yeah. But they say for instant stenosis, the information is
I think
Laser is better.
we will have a discussion on Jetstream because the Boston guys will have a 10% off.
No, sir, but efficiency even how do you select the cases? Which atherectomy? I'm asking you.
I think it's a personal.
I think your duration, if it's acute to subacute, it could be combination of atherosclerotic plaque and thrombus over it. Rotarex is better. Rotarex.
The instant stenosis.
That is laser.
The instant stenosis. Provided you can get through the first is, if you're not sure you are
Translucent, it has to be
true lumen to true lumen right through. If there's even a 1% doubt that you don't have it even, don't use that technique. And this will land up in the hospital. Ideally, it is a failing stent. In spite of failing stent. Say an SFS, typically you see so many long SFS stents, bare metal stents. Right? So when they start
Failing and you get a new one, that is probably, I feel, the best indication for an atherectomy device.
So even now there again, if you have space, sometimes if you have space for putting in a filter, say into the SFA, and you have space to put say distal popliteal, you have space to put a filter, then probably jet stream is a good option. Because jet stream definitely there is muck going down. I mean, whatever whoever might say, we all heard and we all experienced, right? Whereas if it's the Stealth 360 probably doesn't clean up as well as a jet stream, but the distal embolization is probably less. Because and the particles are much finer. So probably if you just want to get a channel, then Botox is a very powerful, brutal kind of thing. So probably if it's ideally I would think in an instant stenosis where there is thick stuff in SFA. That's probably the best. And of course there are
filter wire. All the filter wire.
yes, it's a challenge. Sometimes I'm not too sure. See, atherectomy has been around in the world for ages. It comes and goes and comes and goes. Right? Sometimes I'm not sure whether it is very, yeah. Even the Rotarex and Jetstream have been around for years.
Here, there was a case against Mustafa.
Yeah.
Only atherectomy.
Only atherectomy.
Where it was even possible solution, but only
Yeah. We next have Dr. Karthik Gupta, and the moderator will be Dr. Pankaj Patel.
Good evening all. So I will be presenting a unusual case of acute limb ischemia. So my patient is a 55-year-old female known case of hypertension taking medications. Presented with a complaint of pain and swelling in left lower limb since 5 days with no other comorbidities. Her creatinine level was 1.8 and injection fraction was 55%. On examination, her left foot was put to touch with a reduced sensation over foot. No foot drop, mild calf tenderness was there, and leg and foot were adenomatous. On the pulses part, on the right side only CFA was palpable, on the left side CFA and popliteal arteries were palpable, but the PTK arteries were not palpable. On duplex examination, left CFA we have a triphasic close but with some high resistance flows. Left SFA it was narrow in caliber and we were not able to assess the SFA properly. Left popliteal it was distended with thrombus. And left ATA PTA there was no flow. On the right side CFA has a 100 centimeter per second triphasic close. So we diagnosed that case as a left lower limb acute limb ischemia with Rutherford category 2A, and we proceeded to do DSA and SOS catheter directed thrombolysis or hybrid revascularization was taken. So this is the first angiogram. Another one, and the other one with the selective on the left side. So, what do you think should be the probable cause or what can be the probable diagnosis? So, we'll take one closer look. So, we have done another angiogram. So, question from my side: what can be the diagnosis? What is the presentation you see? Any abnormality you find there? So basically it is a thrombotic occlusion of persistent with a classification of peeled copper class 2, class type 2A. So,
Could you diagnose that?
sir, based on angiogram, sir, here if we,
No, could you diagnose that?
sorry sir?
Could you diagnose that?
It is difficult to diagnose, but during the presentation she was having palpable CFA and her SFA was not that.
Once you saw this, what was your thought?
During this angiogram, we were not able to see the distal flows and internal iliac artery was pretty much having a large branch and which was connecting downwards to the CFA region in this area. This artery, there was no flow. So we thought something is there and we diagnosed it as a persistent sciatic artery which is arising from the
How did you
internal.
diagnose?
Sorry sir.
How did you diagnose that?
Based on angiogram sir only.
On this?
Yes sir.
This will give you an idea.
Remarkable, I would say, remarkable.
Now, how do you diagnose the PSA on this?
Yeah.
Sir, just based on angiogram
So the point is, you cannot diagnose PSA on this, right? A CT angio or MR angio should have given a good clue before you would have gone for DSA. But
Exactly.
I cannot take your word that you diagnose on this.
we didn't do a CT angio sir.
No, I cannot take your word that you diagnose on this.
Sir, it is not diagnose immediate image like this, but to diagnose this,
Yeah.
you have to be a real.
We had some more images as well, but I was not able to put it there. It was not clear per se. But further images are also there, sir. I will show it. I know it is difficult to say just based on 2D image. There should be some angle and rotation. Based on that, we can diagnose it. But this is just to revise that basic anatomy. This arises from the internal iliac artery which was joining the popliteal artery. So we started her on CDT for 12 hours just to see whether the thrombus will clear or not. So it was not clear. We tried to do CDT, but there was no improvement. And again, here we
What did you use?
Sir,
What's the thrombolytic used?
Active sir, Alteplase,
How much?
1 mg per hour
What? How long?
for 12 hours, sir. Sorry? APTT, sir. Ideally should be done with the serum fibrinogen, but it is not available in our area.
It was at the tip only. The catheter was not intra-lesion.
No, sir. We just put it on. We embedded the catheter into the internal iliac artery where the PSA was arising. So we just kept the catheter over there and started her on thrombolysis.
What was the acute ischemia stage?
2A, sir.
2A.
Yes.
So how do you decide to say
Probably did not was
She presented after 3 to 5 days and it was not per se, she was not in that much of pain and we hope that will rise and it will resolve and we will able to see any unmasking of lesion is there, so we'll get a clear anatomy. We were expecting that.
catheter did you use for lysis?
Vertebral catheter, sir. Vert catheter, 100 centimeter. Right CFA we punctured and crossover. Sorry? No, sir. 8-hole catheter only. We embedded the catheter into the internal iliac artery where the thrombus was there, and we just started her on
Is that
thrombolysis.
correct technique to do? How much 3-4 day old thrombus? You put the catheter to the top of a column of thrombus and expect that it will percolate down. Why did you not use a multi-hole or a plate?
We thought it will.
Just for the sake of discussion.
Just we were expecting that it will unmask some lesion because the anatomy was not that great and we were not sure whether to continue with that. So
So what is the distal runoff showing?
sorry, distal runoff only popliteal was visible. I have not included this in my slide because it was not saved properly in the cath lab. So this is how we have negotiated this wire.
So is this your institute protocol After your doctor, you use DSA and then proceed?
Yes, sir. Most of the time, if the creatinine is elevated, we prefer to do DSA only. And there was some lesion also here in the persistent sciatic artery. So we did ballooning as well, but at this point we actually messed up with the thrombus, and that thrombus got dislodged into the popliteal artery again. So on the thrombus which was hanging because of that lesion, because of the ballooning, and everything was cleared and everything was occluded in the popliteal segment. So we had to convert this into the popliteal embolectomy. This is just a representative image. We will not able to save that image as well. Just a representative. And post procedure on table only.
How did you do popliteal thrombectomy?
Sir, supine position, medial, superior medial.
Where did you open?
Sorry, sir.
Where did you open?
Below knee, sir. Medial incision.
Trachanteric.
Yes, sir.
You control all 3 figures?
Yes, sir. All 3 figures.
Because what did you get?
Sorry, sir.
What did you get?
There was thrombus, a bulk of thrombus, and at the ETA origin also there was a thrombus. PTA was completely collapsed, but we were not able to remove any thrombus from PTA. Only ATA proximal segment there was thrombus, but ATA was so distally was calcified, we were not able to negotiate our 3 French, even 2 French puberty catheter was not able to move across that ATA. So we just relied on to continue with the PTA, and we were expecting that PTA will be there, which will suffice her leg and protect her. On table only, we after doing embolectomy and this her PTA was palpable nicely after 5-10 minutes.
2 questions. Did you put Bugatti retrograding?
Yes, sir.
What did you get?
From PTA we got nothing. From ATA proximal segment we got thrombus.
Retrograde.
Retrograde also we got in the proximal in the distal segment also. In the proximal segment there was nothing. And we have removed that thrombus from the PSA segment, not from the SFA.
Please correct me. You do this in a hybrid lab, right?
Yes, sir.
So after doing a thrombectomy, you already put a catheter in internal.
We have removed the catheter, sir, actually. After we got to know that the thrombus has dislodged distally, we removed the catheter, we started heparin from the sheath and converted into an open thrombectomy.
So which sheath where?
Right groin, sir. Right CFA.
You could have taken a picture from the top, right?
Yes, sir, we could have taken, but
Was it a transverse arteriotomy or?
longitudinal arteriotomy, sir. We did cash class C as well. Okay. Actually, we were in so hurry, so we were not able to collect the pictures.
For the PSA, no?
Yeah.
PSA, nothing, sir. Just a close follow-up.
Why should the PSA get a thrombus? What is the etiology?
Actually, there was some lesions, sir, we noticed during ballooning. So, I think that may be the cause.
Generally, why does PSA cause a thrombus?
Maybe because of the seating position, erosion, that may have caused the.
Causes aneurysm, right?
Yeah, most of the time it causes aneurysm, but there was nothing other than this. So we continued just a close follow-up.
What about other side?
Sir?
Other side.
Other side was completely normal. The right side there was no PSA. And actually in the literature it is the incidence of this type of situation is 0.06% only.
So what is the recommendation for a type 2A? What is the recommendation?
Ischemia.
With ischemia. What is the recommendation?
Recommendation is basically you just have to treat the disease and keep her on close follow-up. If she develops symptoms of the PSA.
You have not treated the disease, the PSA?
Yes, sir. Yes, sir. Actually, it is a type 2A, so distal SFA was not developed. So her PSA was basically supplying the popliteal artery. So to treat the disease, we have to do bypass and to correct.
Remove the primary pathology, right?
Yes, sir. We have not. Correct.
What is the correct recommendation?
Basically, she was poor, so we didn't do anything much, and we kept her on close follow-up. In future, if she develops some symptoms, we'll do something for her.
Thank you, Dr. Karthik.
Okay. And one announcement, sir, as well. We are starting one institute in the name of Central India Institute of Vascular and Neurovascular Sciences, posting for Central India population, and also a CME on vascular emergencies as discussed. The date will finalize later, but the topic this year will be on vascular emergencies, all sort of vascular emergencies, artery vein. Okay, thank you.
Thank you. So we next have Dr. Amit Rani, who will be
Whose program is this?
Mine.
and the moderator is Dr. Kamil.
Me again? This is your last presentation? Okay.
Today I am going to discuss a case of So she was a 55-year-old lady. She came to us with abdominal pain.
Yeah, we have Mangaret. What is it?
So she was a 55-year-old lady. She came to us with abdominal pain for 3 months, 4 months duration. She was hypertensive and she had ischemic heart disease for which she underwent coronary angioplasty in previous year, almost 6 to 7 months back. She was evaluated for the abdominal pain with ultrasound ultrasound. They diagnosed that there is a aneurysm over there, and that is how she was referred to us. She had no fever, no weight loss, no TB contact, no recent admission, no trauma. Abdominally, there was a large aneurysm palpable, approximately 5 to 6 centimeters in the length, which is pulses. All investigations were done. Her hemogram, renal function, liver function was essentially normal. ESRCRP was raised. As it was suspected that there is a narcotic element in that, we had sent blood culture and blood for gram-negative, which was negative, which we had kept for prolonged incubation. So we can see here the stool aneurysm, which was arising from that point here. It was big, and we didn't understand why she should develop stool aneurysm at that time. The only thing which happened with that lady was coronary intervention in the past, which was 6 to 7 months ago. No other positive history, everything fine. There was small abscess-like findings over around the left psoas region. So this is a side image of the lesion. So there was a thickened wall around the election was around the left psoas. We have taken the ID opinion and broad spectrum antibiotics were started on intravenously so we could decide whether it was to be treated local, endovascular, or whatever we wanted to give an adequate cover of IV antibiotics, which was given with initially Miropico, Miroplanin and Miroplanin and Ticoplanin, and later Ticoplanin was stopped and it was given daptomycin. We also did the PET scan for this lady, and the PET scan showed that there was an uptake around that psoriasis, and also there was an uptake around that left psoas axis. PET did not pick up any FDG activity but for that aneurysm and left psoas and some paraortic node. But we had a strong suspicion that coronary intervention must have caused this. So, with the discussion with our physicians, we had started her on keto diet. I wanted
ID guy.
ID guy, Dr. Devashish.
Physician will not tell you this.
Yes, sir. With the advice of
This is a lesson for everybody. In order to pick up repeated after keto diet, it's very important.
so
With your diet, you want to pick it up.
yeah, sure. So we had taken the concept of our idea of the Vessomag and we suggested that we should start our own keto diet so that whatever normal uptake is there in the myocardium will be suppressed as the body is going into the ketosis. So we started them for on keto diet for 3 days and we repeated the first time. It was done and it did show the uptake. So the coronary stent got rid of the infection as we can see here. So the pathology was, the inciting event which could have caused this is coronary intervention. Suspected that it was outside the
From only one catheter. This is second case
second.
from one catheter.
So we were discussing whether to do open or no, but the walls around that region were fragile. There was too much of a collection around that was very mostly. And whatever may have been our selection, she had an infected state along. So we went ahead with the CRAT procedure. This is a
Ideally, open would have been better. Using SFP, both sides. For some reason, it's very reduced.
This was we had used 12 by 13 for aorta and 10 for bilateral, except for the CRAT procedure. After the procedure, she was again given 1 month of IV antibiotics in form of mirafinamide as well. She had come after 2 months of follow-up. She was stable, symptomatically relieved. They did the STT angio. There was still mild uptake in that aneurysm, which could have been seen some small leak, but she was not symptomatic, so we had continued her and did her scan after 3 months and decided to finish. So the discussion we would like to have is how should be the reuse policy. And if at all we are going to decide about using the same material again, how we should sterilize it. It should be zero or it should be silence or how. Because most of them, whomsoever come with this myocardial infection, they have either undergone some procedure outside or there is no stringent protocols followed for the sterilization of the products.
There is no medical legal protection or complication after treatment.
No.
No medical.
Unless somebody clearly pinpoints.
Yeah.
Like for example here, first they didn't pick up anything. But there was a very strong clinical suspicion.
That's a good learning.
Exactly. They told keto diet, and it was strongly suspecting some infection, post-intervention.
Amit, what is your antibiotic protocol in this patient?
Sir, our antibiotic protocol usually we discuss it as we are very liberal about taking IDOP. With this patient, we had discussed it with him. So he suspected there was one more patient who died after such infected coronary stent. So that I will discuss briefly. It was blood was taken differently for cultures for that patient, not for this patient, and nothing grew actually. So it was kept for prolonged incubation. Still nothing grew. So they did the ZN of that, and they found out that there is some artificial mycobacterial infection. So whatever is happening, this kind of infections are happening, predominantly it is because of side X. Because side X is able to kill all the organisms but not for artificial mycobacteria. So for this, their antibiotic protocols are going to be prolonged, vaccine and everything.
Correct, no, but a lot of people are still using
Still
it
using
over.
it.
In fact, if you're using orbital satellite device, it has to be used in 12 hours. If you want to use it in 2 patients or 3 patients, it has to be 12 hours. How do you sterilize that? Silence.
So this patient culture negative comes to normal. She was not symptomatic. Still, we decided to cover all the gram-positive, gram-negative. So initially, we started her on mirabegronide teicoplanin, and then we decided that he is not suspecting anything that big a thing. So he wanted to put a daptomycin cover.
How do you prevent an endo leak in serum? If, for example,
Size up.
so do you use a proximal cuff again from one layer?
No,
It's not two
it
barrels.
was a very big graph. It was
Two barrels.
So,
2 barrels inside one big
There is an
barrel.
aortic lumen.
yes,
So
yes.
between the aortic limb and the limb,
Yes.
both limbs, how do you prevent an endo leak? If there is an endo leak, what do you do with the limbs?
So to prevent the endo leak, we had measured
Drop
the
balloon we can do it.
What step?
Proximal.
this was a big graph.
But point is, this is your infection in the vascular system, which is what was a false aneurysm. But I have seen atypical mycobacterial infection in another center in hernia surgery, where they presented with long-standing sinuses from hernia wounds. In fact, a couple of patients who developed this the surgery before. And then they found that it was atypical mycobacterial from sinuses.
Would you use silencing or mesh?
I don't know.
It would be
For discussion, if we have a strong suspicion for this kind of patients and we search them, there are more numbers than what are actually there in the literature. Because now there are catalogs in all small places and district places and taluka places also. And we know by ourselves that they are just using the sheet till that time that it is not breaking off.
What is the recommended overlap?
Almost 30%.
1%.
30%.
So this chemo diet for picking up in PET scan, does it pick up the infection only for myocardial grafts or also for
Sir, particularly here the coronary intervention was done, so we wanted to see it is there in the heart alone. Heart will routinely pick up FDG activity because of the usual glucose being the usual metabolic supply. So when our body goes into ketosis, glucose is no more a supply. It is into the ketone body. So whatever FDG was given, that only was seen over there. The routine myocardial activity was supplied.
so that's only for if you are suspecting infection in
Where
the
is yeah, otherwise,
not for us.
otherwise it will just pick up everything.
No, why? Because what happens is sometimes you have these psoas abscess.
It
And you have
will-
got something. So everywhere psoas will pick up. But the question is whether the graft is this. Like for example, there is one patient which is doing the rounds. This is a lady who had colostomy done for bowel dissection for malignancy. She got a colostomy, got a psoas abscess. And she's had a leak from the iliac. And they have put one covered stent, bought time. Again, after a few months, one more leak, put another covered stent.
So what's it where?
With iliac.
Artery.
So now it's picking up. And this is expected. Now this is a totally hostile abdomen. And with already infection there, it's going to be a nightmare to do anything.
After every second week call आता है.
No, she is developing false aneurysm.
So now she's got hematology.
So we are connection.
Thanks, sir. We next have
So, another point is that over a period of time, at least we have realized that the role of IDD guys is extremely important. More and more because we are seeing so many complex cases. Infectious disease specialist is kind of neglected or ignored by all other medical professions. Including physicians, you name any medical man, they don't want to involve IDK. I do not know why, for whatever reason. But ours too. And when we started involving our ID guy, so many things are happening and opening to us, enlightening us. You know? So it's very important that in your hospital setup, if you are getting similar kind of cases, involve the ID guys rather than beating around the bush.
So, but we have small ID guy send a referral. First thing like not kindly send the dry shrivel for culture.
No, but it's a learning.
They are agriculturists.
They have learned.
Read reports. They don't know how this happens.
You are including diabetic food infections or any. Involve them right from the beginning. They are good asset in management.
One is from our ID guy. When he started seeing our patients and we were giving right antibiotics according to the culture. Looking at it. We just came in a very bad situation. He said everything is right. The doses, meropenem has to go 2 grams slowly over the 2-hour period as an infusion because it is a time dependent thing. If you give it like the system will start it off and it will get over in 10 minutes, it's not going to work. So slow to final inputs, they do have Sir, it is time dependent killing, so it has to stay in circulation. So gradually you give over a period of 2 hours is what they are.
But on the concentration be less if it's given over more material rather than it's given.
So we load it with 2 grams, first loading dose, and then we continue as well.
First loading dose.
And next, everything, meropenem has to go as a input. I'm just saying that, like this, there are multiple inputs that
Generally, antibiotics work on the basis of half-life.
half-life.
So generally the dose that you select is based on half-life, not what much period you're giving. I'm not understanding. I mean, I'm sure there's a science behind it, but I'm not very clear with.
So involve more frequently ideas.
No, but is that
So understanding is better.
Thank you, Amit. Our next talk is our next case is by Dr. Sunil Vora and the moderator is Dr. Harshit.
I'm just presenting few cases and we will be discussing about the Jetstream, the other atherectomy device, and I would also love to know many things from especially who's used this device in the past. So this is the first case that a 78-year-old gentleman who was diabetic with hypertension and ex-smoker and with a great gangrenous changes since last 2 weeks. So on radiological examination there was calcified lesion in bilateral CFA, big segment on both the sides, but only one limb was affected, the other was quite asymptomatic with multiple collaterals. So this was the run on the angio which I have done from the brachial axis. Okay. Followed by Jetstream device. Once my wire was transluminal, I used the Jetstream device with 4 passes and followed by balloon angioplasty and DED balloon ranger. So this was my post procedure result. And within 4 hours I have made him walk because it was a brachial access. And he was quite asymptomatic. The pain was relieved on the same side. The other side, some claudication was still there. Sorry? So this was the another case with 72-year-old male, diabetic hypertension with EF of 45% and second to gangrenous with severe rest pain on the forefoot. The CT scan showed a distal SFM peroneal artery, a little small plaque. This was the big small stenotic lesion with almost 90% stenosis, and there was a small plaque in the peroneal artery. Sorry?
Is it a oral plaque?
Yes, sir.
Oral plaque.
Yes, sir. This was a small plaque in the peroneal artery. Yeah, sorry. Then I did jet stream in the SFA. I tried not to do the whole plan, small segments at a time, keeping in mind of embolic event, so that if it even happens, because I was very doubtful how to use the filter, so I didn't use that filter. And I performed the small segment in the peroneal artery as well. This was my post-op result, post-atherectomy device, and then I used the DEB over here as well as in the peroneal artery. The runoff in the ATA was good, but the distal ATA was having small lesion, which I treated only with POBA. And the third case, so this was 62-year-old female with diabetes and hypertension, underwent coronary angioplasty and stenting 1 year back. There was an ischemic toe on the last toe with the diabetic foot changes and ulcer underneath the distal last toe. CT angio was showing a plaque across the knee joint. This is the knee joint. There was a SFA lesion with CTO over the P3 as well as proximal ATA segment. It's not clearly seen over here. Post jet stream, post atherectomy, there was a good flow in the ATA segment, and the distal ATA was quite good, so the flow was achieved, and within a week's time the wound also healed, the discoloration and pain disappeared. That summary is fine. We have to use embolic device, which is a question. How to use that embolic device? If the wire is coated wire, then how to use that thing? And we have to do DEB angioplasty post atherectomy device.
First question: how do you know you are entirely in the tournament? How do you know?
Every time whenever we advance the catheter over the wire, I take a shoot. Whether it's
How do you know you have not gone into submitting money and back again?
Did you have IOS?
sorry.
Do you have IOS?
You require IOS.
Yeah.
Yes.
Otherwise, it's virtually impossible to know whether you are entirely human or not. Secondly, you used the DEB for BTK.
Yeah, both.
Peroneal.
Peroneal also a small.
But is there any evidence for DEBs in BTK lesions? Yes, there is. Where? Tell me some study. It says DEB is indicated in BTK lesions. Huh?
There is a second extension of the impact trial and a Luton's BTK study.
That's all been disproved. This is all company driven. That whole study is fraud. Okay, it's a company skewed data. As of today, there is no evidence of DEB. In fact, the impact admiral showed that the mortality is more with BTK. But there is no
Boston also has a Ranger trial which was done pre-op and post-op.
Go by the company trial. There will be a randomized trial which company trial. Show me one company trial which says that our product was found not to be used. You don't publish.
BTK Lutonix has failed. Only
No evidence as of today.
Slowly must
For BTK. Don't go by the company.
Sir, this jet stream always goes on 7 French sheet. Okay, so my second case was an anti-grade puncture, and my technician was like, we will not give too much of pressure and we will use an angiosafe. So I was like, I am not experienced, so he was like, I will do it, you just be stand by. It was never me to give a technician, but he did it, and then I saw that everything was fine. But this guy bled on post-op day 3.
And you see, I've seen more disasters.
Which angiosafe do they use?
anti-grade.
It comes only 6 and 8 French. So for a 7
So
French,
8 French used.
How do you decide between IVL? Yes. How do you decide atherectomy and not IVL in an SFA with calcium? How do you decide better to do atherectomy, not IVL?
the tight SFA stenosis with calcium, IVL is superior. Whereas long segment calcium, atherectomy will be perfect.
Based on what? Your personal observation?
The
or
coronary
feeling, or
data.
is it either guidelines?
The peripheral, there are no guidelines. It is all based on coronary interventions. For coronary data, they use Rota Pro for long segment calcium.
Look, my personal thing with what I have experienced is all these exciting gadgets. Ultimately, somewhere down the line, we guys are forgetting we are surgeons. And overkilling with endo. I can tell you my own practice, I'm going to see the best CLI results now. Right now, if you want to talk science, I can tell you to vein bypass, there's nothing like it. The dialyzer patient is not fit. You can earn as much money with the bypass as you can with the. It's just that this is more exciting to use sometimes, right?
Short-term goals.
Short-term goals. Long-term still nothing like a good old vein bypass. RDA. Sometimes we are forgetting it. We are surgeons. That when more people, if you are disadvantaged veins, then even then sometimes I use composite. Recently, in 50 cases, I have tried. Still, it's better than
The kind of calcified vessels and the bad species vessels that you see, when you expose that, they are like rocks.
Those are not very easy for bypasses, and endovascular in those cases are limb salvage procedures. I'm saying it, but yeah.
Finally, you have to. Generally speaking, I find the trend is now to go more aggressively into.
Yeah. Also they are stenting right from origin to bifurcation.
My point.
You should not forget that it's surgeon.
My point is that in the unit, if you want to keep your ingredient vascular surgery busy, you will do it.
Thank you, sir. We come to our last case scenario by Dr. Ishita Jaiswal and the moderator is Dr. Abram Shekhar.
Good evening, everyone. Today I am presenting an interesting case scenario. So, 32-year-old gentleman, otherwise healthy, no comorbidities, presented with left lower limb tingling and numbness, which was insidious in onset, and there is no associated history of trauma. The symptoms are since 1 year. He also complains of left medial pain radiating to left lower limb. The provocative factors for this pain is sitting and prolonged hip flexion. The patient has no addiction, there are no comorbidities, and there is no special family history. Patient is not an overweight patient. Initial management history, it is non-specific diagnosis of cardiac syndrome, and patient was seen where he was conservatively managed under orthopedic and musculoskeletal physiotherapy team. On examination of the left side, femoral pulse was not felt, whereas the popliteal and the PTA pulses are felt and ETA signals were present. On the right side, femoral, popliteal as well as PTA pulses are felt. So, I would like
right side is
What is the condition where the femoral pulse is not available for the hospital?
What is it?
That is the condition where the CFA is not valuable in a young patient. Positive email is valuable.
वही कैसे है वही है
नहीं है
आदमी है
So, like as everyone suggested, I have my different diagnosis before.
नागपुर से पूरा ज़्यादा नजदीक है मुंबई जाने की जरूरत नहीं है
So, differential diagnosis in terms of musculoskeletal, neurological, and vascular DDs. I have piriformis syndrome, hamstring tendinopathy, neurological lumbosacral radiculopathy, vascular persistent sciatic artery syndrome. One of the DDs. So, we got a CT angiogram for the patient.
but you said patient is poor है वही है
So on CT angiogram, we found that the left internal iliac artery is dilated and is continuing as a persistent left sciatic artery into the thigh through the greater sciatic foramen, continuing as a popliteal artery. Also, the left superficial and deep femoral artery is small in caliber and with normal contrastive circulation. So the diagnosis based on the CT angiogram was left vessel type 2A persistent sciatic artery, wherein the persistent sciatic artery is the dominant arterial supply of the left lower limb. There is no evidence of aneurysm or thrombosis in this artery. There is no ischemic changes or distal embolic phenomena.
How do you explain this?
So if you can see on the the sciatic nerve which crosses through the inferior part of the sciatic foramen, also the persistent sciatic artery passes through that, it compresses over the nerve and facial system. So classification system, system, there are total 5 classes. There is our patient is type 2A, wherein the persistent sciatic artery is complete and there is SFA is incomplete. So, going back to embryology, the sciatic artery is the primary embryonic vessel supplying the lower limb until the external iliac system matures. Normally, it involves by the 12 weeks of gestation. If there is failure of regression with variable contribution to the adult lower limb arterial supply, it is called as persistent sciatic artery. The anatomical course faces it in close proximity to the sciatic nerve, which then causes the mechanical compression and especially in the seating posture. Pathophysiological, there can be a compression neuropathy which can be seen in this patient. The mechanical irritation or compression of the adjacent sciatic nerve, particularly in the hip flexion. Vascular complications like aneurysmal degeneration is the most common complication with 40 to 60% of incidence. Distal embolization, rupture and critical ischemia can also be found. The common but the pulsatile mass may not be clinically appreciable in young and may not be clinically found. Based on the classification system, what are the clinical implications in this case? So type 2A, the PSA was dominant, can have a compressive or an embolic risk. Type 1 has a dual supply, there is a low surgical risk. Type 2B, PSA is complete, but the SFA is aplastic, sole supply, and the intervention type can be quite challenging for such patients. Type 3 are usually asymptomatic. Type 4 can be the most common type wherein aneurysm is found. Type 5 can be bilateral. So in our case, type 2A, dominant persistent sciatic arteries with an hypoplastic SFA and compressive symptoms. So management based on the classification on the clinical staging, there is clinical staging based management. If the patient is asymptomatic and there is a complete PSA, which is seen in type 1, 3 and 4, the management is usually observation with an imaging surveillance. If there are only compressive symptoms responding type 2A, the management will be lifestyle modification and surveillance. Unreasonable PSA can, with any type, the management is usually a surgical resection along with a bypass or an endovascular embolization. In clinical presentation is limb ischemia or embolism, 2A or 2B, urgent bypass tracking along with vasodilation. So our patient with type 2A was advised a lifestyle modification in terms of changing usage of proper, changing the sitting arrangement, wherein usage of donut kind of cushion or can be used.
Ring cushion. Or shouldn't sit? What is the follow-up you want to do?
So I would like to have firstly clinical surveillance, and if the patient has an increase in symptoms, we counsel the patient in terms of like currently patient doesn't have any limb ischemia symptoms, only has a pain, so which can be managed with the antacids, NSAIDs, and we've asked the patient for lifestyle modification. But with onset, if the symptoms worsen, the patient may need a bypass. Now, considering bypass, how many of you would like to go ahead and do a bypass in a 31-year-old patient without the patient having a threatened limb? Though the incidence is 0.02 to 0.65, there are two cases we are seeing today.
What was the duration of the history?
So he gave history of 1 year, sir.
Obviously, the persistent scientific is there. Generally, people in the student days in school, they will sit for a longer period in the class as compared to somebody. So, how do you explain that it only comes since 1 year and it goes down here for so long?
Maybe it was, he had his symptoms which are also
Change in patients not lifestyle, but putting on weight or losing weight or something like that.
No, he denied in history, and he's not like clean, but it's like normally built, and he's not an overweight person.
Thank you, Dr. Ishita. So now we are done with the case
I
presentation.
have a question, Anil,
Sure.
for the entire crowd here. When you have a patient of acute ischemic leg or subacute ischemic leg and your Doppler is suggestive of thrombosis, what's your next investigation? Anybody?
I would go detail first.
Amazing. So, absolutely right. I mean, it's just an persistent sciatic artery pathology. I dealt with a patient who came to me third time with thrombosis. First 2 times he had a thrombosis diagnosed acute ischemic leg. Surgeon did only thrombectomy without doing any further investigation. Rethrombosed again after 2 weeks or months. Again did a thrombectomy without doing any imaging. Third time rethrombosed again, and then he came to me. Imaging, CT at the shoulder, thrombosed, persistent sciatic artery aneurysm, embolization. So the point is that do not rely only on Doppler. You must have better imaging, especially for any thrombotic cases, and more so if you are taking the patient for surgery.
We come to the sponsors.
And what I do not understand, once I by at least second time to follow imaging, don't keep on doing the same mistakes again and again and again.
The post embolism, it is will be or any imaging.
Completion angio.
Yes.
If you have a,
I think
completion
more
angio.
information is required.
Yes.
So whenever you have a thrombus anywhere, it depends on